Barrett's esophagus is the squamous lining of the esophagus when has a metaplasia to columnar lining. So when a squamous lining of the esophagus changes to a columnar lining, it is called Barrett's esophagus, and this Barrett's esophagus may progress to have dysplasia and can lead to adenocarcinoma of the lower end of the esophagus. This can lead to adenocarcinoma of the lower end of the esophagus. So this condition, important to note, is a pre-malignant condition. This condition is a pre-malignant condition. Now, very important point, this metaplasia, the most common type of metaplasia which happens here, a very commonly asked question in exam, is intestinal metaplasia. It is intestinal metaplasia. Now, another very important thing which we should remember, that this squamous lining of the esophagus is changing to columnar. So when it is in the stage of metaplasia, important point, highlight that in the notes, it is reversible. You can reverse this metaplasia if you intervene at a right time. But once a dysplasia develops, it is an irreversible change. And this dysplasia will be a malignancy, and carcinoma esophagus is a very aggressive malignancy. So we should not let this metaplasia to progress to dysplasia. So how can we prevent this metaplasia to dysplasia? If we diagnose it aggressively, and obviously if we manage it aggressively, then only we can prevent this metaplasia to progress to dysplasia. So how are we going to diagnose it aggressively? What is the investigation of choice for this? Investigation of choice for this is endoscopy. Now, can anyone tell me that this is a metaplasia, right? So it's a microscopic change. Now, can you make out a Barrett's esophagus through naked eyes? Yes or no? और I don't know. एक एग्जाम में चॉइस होनी चाहिए I don't know. लाइफ सॉर्टेड हो जाए ना. एक चॉइस हाँ और क्या, जैसे नोटो होता है वैसे एक I don't know भी होनी चाहिए चॉइस. उसका नंबर भी होना चाहिए. कम से कम आप ऑनेस्ट हो. ऑनेस्टी के पॉइंट तो मिलेगी. So is it can be seen? Okay. Can be seen on naked eyes or not? What? तो हिंदी में yes or no? Yes or no? Yes or no? No. एक्सप्लेनेशन तो यस वाली दे रहे हो और आंसर दे रहे हो नो. ये ठीक है, एमसीक्यू के जो डिफरेंट सोर्सेज के बिना हो गया. तो एक्सप्लेनेशन कुछ और बता रही है, आंसर कुछ और बोल रहा है. ऐसा होता है ना कई जगह पे. So it was a question asked that this change one can see through the naked eyes also, right? So one can make out on the basis of the visual inspection also, right? Now, let us see who will answer this right. So if I ask you now, What is the best or ideal treatment for a Barrett's esophagus? Can anyone tell me? काट दे क्या काट दे esophagus काट दे ना होगा बांस ना बजेगी बांसुरी सही है you are the right candidate for surgery बोलो हाँ in notes we have already written what are the indications of surgery in GRD. Complications. So isn't it a complication? So the ideal treatment for this condition is laparoscopic Nissen's fundoplication. The best treatment or ideal treatment for this condition is laparoscopic Nissen's fundoplication. But since this condition is a benign condition, most of the time the patient doesn't agree to a surgical procedure for this benign condition. So if you are asked what is the best treatment or ideal treatment, the answer will be this. But if you are asked what is the treatment of choice, because most of the time patient agrees to this, the treatment of choice for this is lifestyle modifications with a high dose proton pump inhibitor for at least 6 months with annual endoscopy. Lifestyle modification with high dose PPIs with annual endoscopy is the treatment of choice for Barrett's esophagus, a question many times asked. Then comes, there is a condition called hiatus hernia. Now, what is hiatus hernia and how do we proceed in hiatus hernia? We should know. Hiatus hernia, the most important, a question asked, most important pathophysiological cause for hiatus hernia is weakness of phrenoesophageal membrane. Most important pathophysiological cause of hiatus hernia is weakness of phrenoesophageal membrane. Now there are 4 types of hiatus hernias. Type 1, which is the most common type, and type 1 is a sliding type of hiatus hernia. बच्चे डर गए डरपोक नहीं Type 1 is the most common and it is sliding hernia. Type 2 is rolling or paraesophageal type. Type 3 is mixed type, and type 4 is mixed with other abdominal contents in thorax. Mixed with other abdominal contents in thorax. Now, most common type is a sliding type of hiatus hernia. Now, what is this sliding type of hiatus hernia? Let's understand. In this sliding type of hiatus hernia, what happens is, if this is the hiatus opening, in the sliding type of hiatus hernia, the lower end of the esophagus is in thorax. In sliding type of hiatus hernia, the lower end of the esophagus is in thorax, while in a rolling type of hiatus hernia, the lower end of the esophagus is in abdomen though, but part of the stomach is in thorax. And there was a question asked, which part of the stomach most commonly goes into thorax in rolling type of hiatus hernia? It is gastric cardia. If not in your choice, then it is fundus. The part of the stomach which goes in thorax in rolling type of hiatus hernia is gastric cardia, followed by fundus. Now, very important point. Where is it? Not in the stomach, in the abdomen. Esophagus is there in the abdomen. Okay, part of the stomach goes in thorax. Now, in case of sliding type of hiatus hernia, very important point, sliding type of hiatus hernia and GRD. Please remember this. GRD and a sliding type of hiatus hernia. Both these conditions, they have a similar presentation. They have a similar management. Whatever presentation you have seen in a GRD, the typical symptom, the atypical symptoms, whatever management you have seen in GRD, that is the first line of management and the indication of surgery and the surgery also. Everything about sliding type of hiatus hernia is exactly same as a GRD. So GRD and sliding type of hiatus hernia are interrelated. GRD and sliding type of hiatus hernia are interrelated. So if I ask you, what is the most common complication of sliding type of hiatus hernia, what will that be? GRD. The same complication which we have it in GRD will be here also. So everything about GRD and sliding type of hiatus hernia is same. The only difference, mind it, the only difference is about the investigation of choice in hiatus hernia. What was the investigation of choice in GRD? It is endoscopy. It is endoscopy. Gold standard is 24-hour pH monitoring. And the investigation of choice here is in hiatus hernia per se, as per the latest, is CT scan with oral contrast. CT scan with oral contrast. Please be careful about it. It has to be with oral contrast mentioned in your given question. Only CT scan will not be the answer. It has to be CT scan with oral contrast. If CT scan with oral contrast is not there in your choice, if by any chance in your given question CT scan is there but with oral contrast is not there, so then it won't be answer. So what will then be answer? Barium meal in Trendelenburg position. Barium meal in Trendelenburg position. Trendelenburg position, you should know, is a head down position. Head down position. Okay. So this will be the answer if CT scan with oral contrast is not in the choice. Okay. Now, in case of a rolling type of hiatus hernia, please be careful about it. The most common presentation of a rolling type of hiatus hernia, the most common presentation of a rolling type of hiatus hernia is retrosternal chest pain. Retrosternal chest pain. An important point about this retrosternal chest pain, what was the nature of retrosternal chest pain in GRD? Nature, burning type. Here it is a colicky type of pain. Here it will be a colicky type of pain, and the patient will also have retching. Retching is patient is trying to vomit, but the vomiting is not coming. That is called retching. And very important point, once the vomiting comes, vomiting relieving pain is a classical presentation of a patient of a rolling type of hiatus hernia. And the treatment of choice for this condition is always surgery, and the surgery here also will be laparoscopic Nissen's fundoplication. The surgery here also will be laparoscopic Nissen's fundoplication. No, no, no. In duodenal ulcer, the symptom is the pain getting relieved after taking meals. No? Right? So, treatment of choice is laparoscopic Nissen's fundoplication. Now, then comes the functional disorders of esophagus. Now, can you enumerate the various functional disorders of the esophagus if you know? Eclasia cardia, very good. Any other you know? Diffuse esophageal spasm. Any other? Nutcracker esophagus. This nutcracker esophagus is also called jackhammer esophagus. This nutcracker esophagus is also called jackhammer esophagus. Okay. Now, can anyone tell me out of these various functional disorders, which of them is the most common functional disorder? Just because you know more about eclasia cardia doesn't make it a most common functional disorder. The most common functional disorder is nutcracker esophagus. But having said this, most common functional disorder of esophagus presenting as dysphagia if asked, then it will be eclasia cardia. But most common functional disorder of the esophagus in general is jackhammer esophagus. Now, let us talk about eclasia cardia. Now, this statement, the definition of eclasia cardia, which I am going to make you write down, every word has an MCQ in this. Presenting as dysphagia. Now, in eclasia cardia is a condition where there is a selective loss of inhibitory. There is a selective loss of inhibitory myenteric neurons. There is a selective loss of inhibitory myenteric neurons in Auerbach plexus of esophagus, which were earlier secreting nitrous oxide and vasointestinal peptide. So this definition is very important. Every word has an MCQ here. Selective loss of inhibitory myelinic neurons, Auerbach plexus, nitrous oxide, and VIP. Vasointestinal peptide. Vasointestinal peptide. So because of a selective loss of inhibitory myelinic neurons in the Auerbach plexus of esophagus, what happens is there are certain manometric changes which it leads to. There are various manometric changes happens due to this selective loss. What are the manometric changes? One, there is failure of relaxation of lower end of the esophagus happens. So the lower end of the esophagus fails to relax in this condition. Second, there is aperistalsis or there is a weak peristalsis. There is a aperistalsis or a weak peristalsis. And third, the tone of lower esophageal sphincter in this condition is high. Tone of lower esophageal sphincter in this condition is high. So these manometric changes are important for our exams. Now, how the patient is going to present to us? Most common age of presentation is 30 to 50 years. So this age of presentation is important for us in a clinical question. You have to be careful about this age criteria. It is more common in females than in males. And the most common presentation in these patients is very important presentation which we should know is dysphagia. And the classical point about this dysphagia, very commonly asked thing, the classical point of this dysphagia is that this dysphagia is initially to liquids, then to solids. So in any given question, if you are told that the patient has a dysphagia to liquids to start with and then to solids, it is eclasia cardia, right? Please be careful about it. And another very important point about the dysphagia of eclasia cardia, this dysphagia of eclasia cardia is a progressive dysphagia. Usually a progressive dysphagia, but it can also be a non-progressive dysphagia. Most of the time it is progressive, but it can be non-progressive also, but usually it is progressive. But please highlight that in your notes. It is never intermittent. It is never intermittent. What do you mean by intermittent dysphagia? कभी हो रहा है, कभी नहीं हो रहा है, right? Okay. Then patient can also present to us with a retrosternal pain. Patient can also present to us with a retrosternal pain. There can also be halitosis. What is halitosis? Yes. So halitosis is foul smell coming from the mouth. Now, what will be the first investigation you are going to do if such patient comes to you? Very good. The first investigation we are going to do is barium swallow. And what you get in barium swallow? Bird beak, pencil tip, or rat tail is more suggestive of carcinoma. What else we get? I told you. I told you. I told you. S shape or sigmoid esophagus also. S shape or sigmoid esophagus. Now, investigation of choice here is manometry. And there is classical chest X-ray finding also there in these patients. There is classical chest X-ray finding is also there in these patients, and which they have also asked many times in exam. The classical chest X-ray finding here is absent fundal gas with air fluid levels in mediastinum. Absent fundal gas with air fluid levels in mediastinum. Very important finding. And then comes the most common complication. The most common complication of ecclesia cardia is, very good, it is esophagitis. Now, can you tell me, is ecclesia cardia a pre-malignant condition? Yes or no? अभी तो can be था. Can be है, but no. ये कैसा can be है? Yes or no? Answer is yes. Answer is yes. And very important point, this ecclesia cardia leads to which type of carcinoma esophagus? Squamous cell or adeno? Squamous cell carcinoma. This ecclesia cardia leads to squamous cell type of carcinoma, and this carcinoma happens in the dilated, important point, dilated segment of the esophagus. This carcinoma happens in the dilated segment of the esophagus. Right? Now coming on to the treatment options. What are the treatment options we have in ecclesia cardia? Very commonly asked question again. The treatment option we have are calcium channel blockers or nitrates, botulinum toxin injection, pneumatic dilatation, POEM. What is POEM? Per oral endoscopic myotomy. Per oral endoscopic myotomy, and we also have the option of laparoscopic modified Ehlers myotomy, which is also called or Heller-Dor operation. Laparoscopic modified Heller's myotomy or laparoscopic Heller-Dor operation. And out of these various treatment options, the treatment of choice, if asked, is laparoscopic Heller-Dor operation. And please note one point here, if they keep asking also in exam and you get confused too, this Dor, please note this point. You don't need to go into the detail of this, but you just need to know that this Dor is a type of anti-reflux surgery. So there is a question asked that whether this Heller-Dor operation includes anti-reflux surgery or not. Answer is yes. Right? So anti-reflux surgery is included in this procedure now. Earlier it was not, now it is included. Okay. So these are the things we need to know in achalasia cardia. Then comes another very important condition. GIT. GIT की सर्जरीज में क्या नाम था? What are these surgeries? These are all anti-reflux surgeries. See, basically क्या है? देखो, please understand. What is the reason of GRD? We know that normally the acid is getting prevented to come in contact with the esophagus. Most important factor is intra-abdominal pressure. Then we have tone of lower esophageal sphincter also. We have a length of the abdominal esophagus also. This is what we have discussed. There are many factors. What we are doing here is in a Heller's myotomy. We are doing myotomy, otomy. So what does that mean? We are dividing the muscle. We are dividing the muscle. Which muscle are we dividing? The lower end of the esophagus muscle. So when we divide a lower end of the esophagus muscle, you are decreasing the tone of the sphincter actually. So when you decrease the tone of the sphincter, the reflux will happen, right? So to prevent reflux, we have to add an anti-reflux surgery. Reflux surgery which we add here is Dor. Right? Now coming on to Zenker's diverticulum. Now, can you tell me what is diverticulum? Outpouching. Outpouching is diverticulum. There are two classifications for diverticulum which we all should know. There is something called true diverticulum. There is something called false diverticulum. What is true and what is false? True diverticulum is one which has all the layers of GIT. True diverticulum is one which has all the layers of GIT, while false diverticulum is not having all the layers. It may have one layer, it may have two layers, or it may have three layers, but not all the layers. Okay. Then there is another classification for diverticulum also. Pulsion diverticulum and a traction diverticulum. What is pulsion diverticulum and what is traction diverticulum? Pulsion diverticulum is the reason of outpouching in pulsion diverticulum is because of a pressure change. Because of an increased pressure, the outpouching when happens, it is called a pulsion type of diverticulum. And if something pulls a structure outside, is outpouching happening because of pull from outside, it is called a traction diverticulum. So if it is because of a pressure, it is pulsion diverticulum. If it is because of a pull from outside, it is a traction diverticulum, right? And Zenker's diverticulum is the most common diverticulum of esophagus, and it is false and pulsion type. It is false and pulsion type. So in this condition, because of a pressure inside the pharyngeal wall, the mucosa from the pharyngeal wall outpouches. And from where it outpouches, a very commonly asked question, it outpouches from the weak area in the pharyngeal wall. What is the weakest point in pharyngeal wall in APA? It is Killian's dehiscence. So this Zenker's diverticulum prolapses out from a Killian's dehiscence. And what is Killian's dehiscence? This is a weak spot, very commonly asked question it is. It is a weak spot in the upper oblique fibers of inferior constrictor muscles of pharynx, inferior constrictor muscles of pharynx, that is between cricopharyngeus muscle and thyropharyngeus muscle. So this outpouching is happening between cricopharyngeus and a thyropharyngeus muscle, a very commonly asked question. So this is how the outpouching happens. Now, important point about this outpouching is, again, a commonly asked question. The opening of this diverticulum, is always in the midline. This outpouching is happening in the upper oblique fibers of inferior constrictor muscles of pharynx, that is between cricopharyngeus and thyropharyngeus muscle, and the opening of this diverticulum is always in the midline, while the sac of this diverticulum lies left posterolaterally. The opening of this diverticulum is always in the midline. Opening of this diverticulum is always in the midline, and the sac of this diverticulum lies left posterolaterally, right? So these are the important points here. Now coming on to presentation. Most common age of presentation of this condition is more than 50 years. Please be careful about this point, that you may be provided a clinical profile where the presentation of a patient is similar to eclasia cardia. So eclasia cardia and Zenker's diverticulum can have a similar presentation. So you have to make out a difference between a eclasia cardia and a Zenker's diverticulum. So what will be the difference? One is an age. Second important point is it is more common in males. This condition is more common in males. And then the most common presentation here also is dysphagia though. But important point about this dysphagia here is it is a intermittent type of dysphagia. The dysphagia in Zenker's diverticulum is a intermittent type of dysphagia. One important point, Second, the patient will also have a foreign body sensation in esophagus. Patient will have a foreign body sensation in esophagus also. Patient can have halitosis. Patient can have a dental enamel. Just hold. Hello. Hello. Yeah. Yeah. Hello. Actually, can we discuss this sometime later because I'm in the middle of something. So there will be a dental enamel erosion also. So, what is the investigation of choice for Zenkel's diverticulum? I told you. What is the investigation of choice? Barium swallow. Now, what is the most common complication of Zenkel's diverticulum? The most common complication of Zenkel's diverticulum is aspiration, pneumonitis. Aspiration, pneumonitis. Now, is Zenkel's diverticulum a pre-malignant condition? No. Yes or no? No. Answer is no. Good. Now, in treatment of Zenkel's diverticulum, it depends on its size. The treatment of Zenkel's diverticulum depends on its size. If the size of this diverticulum is less than 2 centimeter, the treatment is myotomy. If it is more than 2 centimeters, then in that case, we have various options. One is myotomy with diverticulopexy. Myotomy with diverticulopexy. We have option of myotomy with diverticulectomy. Myotomy with diverticulectomy. And we also have linear diverticuloesophagostomy. We have linear diverticuloesophagostomy, which is now done endoscopically by using stapler. And what is the name for that? I told you. Dolman's procedure. It is a Dolman's procedure. Right? So, out of these various options, now the preferred one is Dolman's procedure. Preferred one is a Dolman's procedure. Okay. Now then comes carcinoma esophagus. Most common site, most common type. Now this question, there's a lot of confusion on this question, but the answer to this is, if you are asked most common site, it is middle third of esophagus, and most common type is squamous cell carcinoma. If you are in US, which you are not, or if you are writing MLE, which you are not, then it will be adeno, lower end of the esophagus. But worldwide, it is middle third squamous. There are few risk factors which we need to know for carcinoma esophagus. They don't focus these days on the risk factor part. They focus more on the approach and management part. But then there are few risk factors which we have to know, like age is a risk factor here, smoking is a risk factor here, alcohol is a risk factor here, and achalasia cardia we know is a risk factor. Barrett's esophagus is also a risk factor, we know it. And corrosive stricture, important point, is also a risk factor, which is also called lye ingestion. Lye ingestion leads to, is a kind of a corrosive material which leads to corrosive stricture, so it's a risk factor. Then radiation, important point, is a risk factor. Plummer Wilson syndrome is a risk factor. An important point, this is important. In Plummer Wilson syndrome, the most common site of carcinoma esophagus is upper esophagus. This is important here. And then the protective factor is also important. One protective factor which we have to remember. It's a question which they commonly check also. In protective factors, very interesting, H. pylori infection of stomach. H. pylori infection of stomach is protective for lower end adenocarcinoma. H. pylori infection of stomach is protective for lower end adenocarcinoma. Now, coming on to the presentation. Most common presentation. What will that be? Dysphagia. And very important point to know, this dysphagia is a progressive dysphagia. It's a progressive type of dysphagia. Patient can have odynophagia also. What is odynophagia? Pain during swallowing. Odynophagia is pain during swallowing. Patient can also present to us with weight loss and loss of appetite. Patient can also come to us with ascites or jaundice. Now, can you tell me what is the investigation of choice here? It is endoscopy. Endoscopy is the investigation of choice here. Now, what is the investigation of choice for staging? It is PET, CT. If not in your choice, then CT. But if you are asked what is the investigation of choice or depth of penetration of carcinoma esophagus? दिल की नहीं सुननी है, तो नोट्स में वो देखो. एंडोस्कोपिक है ऑलरेडी लिखवा चुके. एंडोस्कोपिक बात ही है ही नहीं. देख जरा नोट्स में क्या है, नहीं है नोट्स में. एक जगह पे सब जगह पे लिखा हुआ तुमने सारा, ऑलरेडी लिख चुके हो. नाउ कमिंग ऑन टू द मैनेजमेंट, आई विल गिव यू अ वेरी सिंपल way of managing a carcinoma esophagus. Okay, now in management of, first of all, can you tell me what is the most common site of distant metastasis from carcinoma esophagus? All GI malignancies except anal carcinoma. So most common site of distant metastasis is liver. Now, in management of carcinoma esophagus, what are the options we have? You should know what are the options we have in management of carcinoma esophagus. We have option of surgery. We have the option of surgery. We have option of chemo. We have option of chemo radiation. And we also have option of radiation. These are the various options we have. First of all, surgery is the primary or main modality. Surgery is the primary or a main modality. These are all adjuncts. They can ask you, is there any role of radiation in carcinoma esophagus? So you should know that yes, there is a role. Now, in surgery, what is the surgery we do? I told you. रेडिकल ईसोफेगस में गैस्ट्रिक क्यों करेंगे? ईसोफेजेक्टमी. तो इसका मतलब अगर इससे कम है कुछ, if anything lesser than this is there, your answer should be only radical esophagus. So if I ask you, let me make you understand this. ये understand करने वाला चीज है, ये एक बार समझ आ जाएगा तो बहुत आसान हो जाएगा हमारे लिए. Imagine I ask you that patient has a mucosal involvement with no lymph node, with no distant metastasis. What is the treatment? Radical esophageal, right? So this way, and if I tell you that patient has a mucosal involvement with a mediastinal lymph node enlarged, what is the treatment? Understood? Very good. Now we are left with advanced carcinoma esophagus. When will you call a carcinoma esophagus advanced carcinoma esophagus? It is once there is a distant metastasis, once there is a distant metastasis, or it is T4. What is T4? Adjacent structures involvement. Adjacent structures involvement. Esophagus के साथ adjacent structure क्या होता है? उससे पहले भी कुछ होता है और ट्रेकिया, वेसल्स अराउंड है ना. सो एडजेसेंट स्ट्रक्चर, अगर एडजेसेंट स्ट्रक्चर इन्वॉल्वमेंट बोला है या डिस्टेंट मेटास्टेसिस बोला है तो इट इज अ एडवांस कैंसर. एंड आई मेड यू अंडरस्टैंड ऑलरेडी दिस. What is our primary objective in management of an advanced cancer patient? Quality of life. So our primary objective in these patients is quality of life. So we focus on quality of life here. Okay. So what is causing a problem in the quality of life of these patients? They can't eat. So that means we have to relieve dysphagia. So to relieve dysphagia, what we do? SEMS. What is SEMS? Self-expanding metallic stent. So to relieve dysphagia, we have option of SEMS. सो डिस्फेजिया रिलीव करने के लिए हमारे पास ऑप्शन है सेम्स. और कोई ऑप्शन हो सकती है? ओपन करके फीडिंग पाइप ट्यूब, विच इज कॉल्ड इन हिंदी फीडिंग जेजुनोस्टमी. सो वी हैव ऑप्शन ऑफ फीडिंग जेजुनोस्टमी. We have option of putting a stent. Preferred is stent. Another problem which is causing the difficulty in quality of life is pain, odynophagia. So we have to relieve pain also. Pain relief. So what have we done by doing this? We have tried to improve quality of life. So this is called palliation of symptoms. Now we also want to improve survival to certain extent. We can't do much, but we should try to improve survival. I made you understand that. So for that, we will add chemotherapy. So the treatment of advanced carcinoma esophagus, is palliation of symptoms with chemotherapy. ठीक है? Out of feeding jejunostomy and a stent, preferred is stent. What is stent? क्या होता है? क्या है ये? इसोफेगस है मान लो, ऐसे कैंसर की ग्रोथ ने making it difficult to swallow. So what we do? We put a tube inside here like this, which pushes this growth and makes a channel like this, something like this. So the patient can eat through. This is called self-expanding metallic stent. Okay, so this is what we need to know in management of a patient. Now, once we remove esophagus, how will you reconstruct esophagus? Which is preferred? Stomach. And on what vessel the stomach is based on? Right gastric and right gastroepiploic artery. Good. Then comes, so this is about carcinoma esophagus. Esophageal perforation. Now, can you tell me, very commonly asked question it is, what is the most common cause of esophageal perforation? खाने से कट गया तो मोस्ट कॉमन है, तो फिर तो हम सब खाते रहेंगे और कटता ही रहेगा फिर। What trauma? It is iatrogenic. The most common cause of esophageal perforation is iatrogenic. What iatrogenic thing है? Huh? Doctor doing it, obviously doctor doing it, but what the doctor is doing leading to perforation? Endoscopy. So iatrogenic, that means is endoscopy. So during endoscopy, most of the time esophagus gets perforated. But please be careful. Please be careful. If you are asked what is the most common cause of spontaneous esophageal perforation, the most common cause of spontaneous esophageal perforation, if asked, it is barotrauma of the esophagus, which happens, and this barotrauma is also called Verhoeven's perforation. What is this Verhoeven's perforation? We will be talking about. So most common cause of esophageal perforation is iatrogenic and most of the time endoscopy, but most common cause of spontaneous esophageal perforation is barotrauma, that is Verhoeven's perforation. Now, can you tell me how will a esophageal perforation patient, you think, according to your understanding, how should a patient of esophageal perforation should come to us? Blood and sputum. Vomiting, very good. Patient may come to us with vomiting. What else? Coughing. काला और सोचो बहुत ज्यादा टाइम से पहले तो कुछ कम टाइम में भी तो कुछ होगा पहले पेन इन एस पेन का severe retrosternal chest pain. जो पेशेंट वॉमिट कर रहा है वैसे नहीं खा पाएगा. और क्या हो सकता है? फीवर हो सकता है? हो सकता है. ओके, नाउ वंस इसोफेगस परफोरेट्स, इसोफेगस में होल हो गया है, तो विल देयर बी एनी एयर लीक? Yes or no? Yes. With every breath we are swallowing air. With every breath we are swallowing air also, so there will be air leak. So once the air leaks out from the esophagus, it will not only go into the mediastinum, it will also come into the subcutaneous plane. So this air from the esophagus may come to in a subcutaneous plane, leading to a condition called subcutaneous emphysema. There will be air inside the subcutaneous plane. So when you put a hand here on the chest of the patient, you will find a crunching kind of a sound. Means there is a air kind of a feeling you will get inside, that is called a subcutaneous emphysema. And these three things together, important point, is called Meckler's triad. These three things together is called Meckler's triad. Patient can have left-sided, important point, left-sided pleural effusion also. patient will have a left-sided pleural effusion also. Now, Meckler's trial. उसमें तो यूरिन आ रहा है, यहाँ पे एयर है, ऐसा वैसा कुछ नहीं है, एयर है, यूरिन है, right? Now, can you tell me what is the investigation of choice? ये इतना सन्नाटा क्यों आज? इतने चुप क्यों हो? Investigation of choice. If not in your choice, I already made you write down all that. Contrast, esophagogram, and the contrast of choice is water soluble contrast. What are the two options in water soluble contrast? Gastrographin and iohexol. Commonly used is gastrographin. So if you are asked what is the investigation of choice, it is CT scan with oral contrast now. If not in your choice, then it is contrast esophagogram. And if you are asked what is the most sensitive investigation, barium swallow. Okay, now this understanding is very important for you. देखो एक ये rule है. Now listen to this very carefully. This will be applicable in any such condition. What is that such condition? In any acute infective GI condition. As a rule, remember. Is it an acute infective GI condition? Yes or no? Yes. It will be acute condition. It will be infective also, and it's a GI condition also. So in any acute infective GI condition, as a rule, remember, the first line of management, सबसे पहले हम क्या करते हैं? The first line of management will be keeping the patient nil per orally. We'll stop anything from the oral route, keeping the patient nil per orally, starting IV fluids with IV broad spectrum antibiotic with IV anti-inflammatory drugs. The first line of management in this is, as a rule, you have to remember, in any acute infective GI condition, the first line of management is always going to be nil per orally, starting IV fluids, IV broad spectrum antibiotic, and IV anti-inflammatory drugs. Okay. Now, please understand this. After this, very important, check many times in exam, if the patient is stable, after this, if the patient is stable, what is stable you know now? More than 90. Right? If the patient is stable and if it is a perforation due to flexible endoscope, if this perforation happened because of a flexible endoscope, or the perforation is of a cervical esophagus. If the perforation happened due to flexible endoscope, or it is a cervical esophageal perforation, subject to condition. Mind it, most important thing is patient is stable. So please be careful in a clinical profile of the patient, whether the patient provided to you in a given clinical profile is stable or not. Okay. If it is stable and it is due to flexible endoscope or a perforation of a cervical esophagus, we will continue with this treatment. Means we will manage the patient conservatively. So management of the patient of such kind only will be conservative, right? But if once the patient is unstable, अगर patient unstable है, once the patient is unstable provided to you in given clinical profile, whatever the perforation may be, even if it is because of flexible endoscope or even if it is in the cervical part of the esophagus, or second, in a given patient, you are told that there is an intra-abdominal esophageal perforation is there. Intra-abdominal part of the esophagus got perforated. Even if the patient is stable, minded, these are the indications of surgery we are talking about. These are the indications of surgery. Patient unstable or patient is having an intra-abdominal part of esophageal perforation, or it is a Barhovis perforation. What is Barhovis perforation? We will be discussing in stomach. So in any of these conditions, you have to offer surgery. So please be very careful here. Even if the patient is stable but having an intra-abdominal part of esophageal perforation, or it's a Barhovis perforation, even when the patient is stable, we will offer surgery. Or wherever the perforation is, once the patient is unstable, then also we are going to offer surgery. Now what that surgery be? The surgery will depend on if the patient comes to us within 24 hours or after 24 hours. If the patient is coming to us within 24 hours, this 24 hours is from the time of patient's symptoms. जब से patient के symptoms शुरू हुए तब से. If the patient comes within 24 hours, your answer should be primary repair with buttressing. What is buttressing? I'll make you understand. If the patient comes to you in more than 24 hours, your answer should be esophageal exclusion. So in a given clinical profile, what all we have to see? We have to see whether the patient is stable or not, whether the perforation is of a cervical esophagus or a flexible endoscope perforation, whether the perforation is there in the abdomen or the perforation is a Barhovis perforation or the patient is unstable. So these features we have to see, and then we have to see that whether patient is coming to us in less than 24 hours or more than 24 hours. So all those things we have to see and then finally decide what is the treatment. So if the patient is coming to us within 24 hours, what we are going to do? This is esophagus. What is primary repair with buttressing? See, please try to understand this. What is this buttressing? What happens is esophagus, we all know, doesn't have serosa. Esophagus doesn't have serosa. Now, what has happened? There is a hole in the. Okay. So what primary repair means? We are going to close this hole. Primary repair means we are going to close this hole. But what happens is, once the esophagus perforates, since it doesn't have a serosa, so because of the inflammation, you all know there will be edema also. And you also know whenever you, in our day-to-day practice, we all have seen that if the paper is wet, any paper, if that paper becomes wet, even when you fold it, it gets torn. So the same thing happens with the sides of the margins of the perforation. So this is edematous wall. So these walls of the perforation, the margins, because of the edema and inflammation, gets very friable. So this fluid which comes because of the inflammation makes this wall very friable. So if we take a suture and try to apply a knot, there are very high chances the knot may cut through. So what we do in buttressing, we take a muscle from the chest wall, or we can take a part of the pericardium and put that part of muscle on this side of perforation, and now we apply knot over this muscle. So we have supported the edges of the perforation by some other tissue. Whenever we support the edges of the perforation in surgery by any other tissue, that type of primary repair is called buttressing. So when the patient comes to us within 24 hours, this primary repair will not be a simple primary repair. It will be supporting the edges of the perforation by other tissue, which is called buttressing. But once the patient comes to us after 24 hours, even when you support the edges with any other tissue, if you apply a knot, the tissue may cut through. So what we do is, we can't do buttressing here, so we can't have the knot applied there. So what we do esophageal exclusion. What is esophageal exclusion? We divide this esophagus. Wherever the perforation is, we divide that side of perforation like this. We divide the perforation like this, the side of perforation like this. And what we are going to do now, we will close the distal end. Distal end को बंद कर देंगे. Proximal end को neck से बाहर निकाल दो. When we take out esophagus and open in the neck, what will that be called? What stomy? Esophagostomy. Right? So what we have done, we have closed the esophagus, the distal end, and we have brought the proximal end of the esophagus out in the neck. Now, how will the patient eat now? So what we do for eating, we will put a tube in the jejunum and let that tube be out from the abdominal wall. So this is called feeding jejunostomy. So for some time what we have done, we have excluded esophagus from the body. After some time, after 6 to 8 weeks, we will bring it back and do the anastomosis. So this is called esophageal exclusion. Right? So if the patient is coming to us in less than 24 hours, we will do primary repair with buttressing. If the patient is coming to us in more than 24 hours, we are left with no choice but to exclude esophagus from the body by doing esophagostomy and feeding jejunostomy. Understood? Everyone? नेक को लाके अंदर कैसे बाहर लाया ना? Antibiotic देंगे 6 to 8 weeks. After 6 to 8 weeks, we establish the continuity. 6 to 8 weeks. नहीं हॉस्पिटल में जरूरी नहीं है रहने की. ठीक है, चलें आगे. कोलोस्टमी जैसे बनाते हैं. कोलोस्टमी सुना है ना? When you take out the colon on the surface of the skin, तो patient हॉस्पिटल में थोड़ी रहता है. Patient go back home, and then later on we establish the continuity. She is saying कि ज़्यादा बातें करने तो बाहर जाके करो, and she is not liking it at all, and I am also not liking it. So whatever questions you have, ask me. ठीक है? So, हाँ? एंटीबायोटिक कहाँ से देंगे? मतलब आईवी लाइन से देंगे? फीडिंग ट्यूब से भी दे सकते हैं, right? So this is all about esophagus. Now any question? Huh? If we keep it open, तो क्या? Chances है infection के हो सकता है, but when we give a cover of antibiotic, doesn't happen. So this is all about esophagus. चले आगे. Now let us talk about stomach. Now in stomach, first of all, let us know the surgical anatomy. Now in surgical anatomy of the stomach, blood supply. Now can you tell me what is the blood supply of the stomach? Celiac artery. What are the branches of celiac artery? What is this branch? What is this branch? Left gastric artery. What is this branch? Splenic artery. Very good. What is this branch? Common hepatic artery. So it is a common hepatic artery. Now from common hepatic artery arises, what is this branch? Common duodenal, right gastric artery. And then what is this branch? Gastro-duodenal artery. And then this hepatic artery, this is called hepatic artery proper, and then it gives right and left hepatic artery. You know that. Now this gastroduodenal artery gave rise to two branches. What are those two branches? Superior pancreatico-duodenal artery. Superior pancreatico-duodenal artery. What is this artery? Right gastroepiploic artery. So this right gastroepiploic artery runs like this. And what is this? What are these arteries? Very good. Short gastric arteries. And what is this branch? Left gastroepiploic artery. Very good. And this image is very important. This was a question, and there was an image in the exam also where they have asked these vessels were there, and they have asked which of them is a left gastric artery in that image. 1, 2, 3, 4 they have labeled. So you should, this image is important. Now coming on to, you all know that all the veins in the body runs parallel to the arteries. We know that, and you also know by now that all the lymph nodes in the body are sitting on a vessel. These are those vessels which are supplying that organ. We know that? Yes or no? So correct me if I'm wrong. Can I say now that there will be a short gastric nodes draining stomach? There will be a gastroepiploic nodes draining stomach? Yes or no? There will be gastroduodenal nodes draining stomach. There will be right gastric nodes draining stomach. Yes or no? Yes. There will be hepatic nodes draining stomach. There will be left gastric nodes draining stomach, and there will be celiac nodes also. Agreed? Yes or no? Sure? Right gastric nodes, short gastric nodes, right gastric nodes, short gastric nodes, gastroduodenal nodes, gastroepiploic nodes, right gastroepiploic and left gastroepiploic, there are the gastroepiploic nodes, then right gastric nodes and left gastric nodes, and hepatic and celiac nodes. Yes or no? Yes. Okay, good. Now, this is a anatomical arrangement of the lymph nodes draining stomach, right? This is an anatomical arrangement. Like the way it was there in breast, there was an anatomical arrangement and then there was a surgical distribution also. What was that surgical distribution? Level 1, level 2 and level 3. In breast, it was level 1, level 2 and level 3. Similarly, in stomach, there is a surgical distribution also. Like the way we have a surgical distribution in breast, similarly, we have a surgical distribution in stomach, right? And what is that surgical distribution? We don't need to go into the detail of that though, but we should know this particular point per se. See, stomach malignancy is having a maximum prevalence in Japan. Now, what Japanese have done, they have studied the lymphatic drainage of the stomach extensively. And what they have done, they have modified the lymphatic drainage of the stomach surgically. And what is that modification? That is important for us. All these lymph nodes, short gastric node, left gastric node, right gastric node, gastroepiploic node, all these nodes were given certain number, right? We just don't need to know which lymph node got what number. Which lymph node got what number, we just need to know. We just need to know that these numbers are called stations. So, say for example, there is a short gastric node, there is some number to that, and that is a station for that. Likewise, left gastric node has certain number, and there is a station, that number is a station for that. So, we just need to know, just don't need to know which lymph node got what number or what station. We just need to know there are 16 stations. There are 16 stations, right? So the lymphatic drainage of the stomach goes to 16 stations, right? Like the way we had it in a breast, there was level 1, then level 2, then level 3. Similarly, there is a D1, D2, and D3 tier. Here it is tier system. Here it is a tier system. In breast, it was a level system. Here it is a tier system. So D1 tier, D2 tier, and D3 tier. Right? हमें ज़्यादा डिटेल में नहीं जाना. हमें सिर्फ इतना याद रखना है कि D2 tier include. हमें सिर्फ इतना याद रखना है कि D2 tier include lymph node along hepatic artery, splenic artery, and a celiac artery. There will be number for these lymph nodes. We don't need to remember that. Celiac node has certain station, a number. Hepatic node has certain station or number. Splenic node also has certain number or station, but we don't need to remember. But this point is very important for us to know, because ultimately when we talk about the management of carcinoma stomach, this will be very important for us. क्या हुआ? Right? ठीक है. तो ये तो हुआ आपका surgical distribution of the lymphatic drainage of the stomach. Okay. Now in stomach, now let me conclude the part here, the surgical part here itself. Like the way we have it in esophagus, like the way we have it in the breast. In surgery, there were two components, wide excision and lymphadenectomy. The same thing in surgical part of the stomach malignancy is also there, and that is wide excision. Whenever there is a stomach malignancy, the treatment of a stomach malignancy is in surgery, wide excision with lymphadenectomy. Wide excision with lymph node removal. And we all know that wide excision everywhere has a limit, right? What was the limit in breast? What was the limit in esophagus? Likewise, here it is 5 centimeter margins on either side. Here it is 5 centimeter margins on either side. And what is the extent of lymph node removal here? It is D2 lymphadenectomy. So stomach की सर्जरी में हमारे MRM में क्या था? जो what is the extent of lymphadenectomy in MRM? Level 1, level 2 always, level 3 if enlarged. Right? In stomach, the extent of lymphadenectomy is D2 lymphadenectomy. What is D2? We know now. What is D2? We know now. Right? Right? Now, this surgery is called radical gastrectomy. This surgery is called radical gastrectomy. Okay? The name for this surgery will be radical gastrectomy. Now, imagine. Now, please understand, because this question keeps coming in exam. When I was at your level, I never understood this. So, what is that thing? Imagine there is a growth here. Okay, and you are doing a surgery for this growth. Right? There is a malignant growth, and you are doing a surgery. You are going to take a 5 centimeter proximal margin. You are going to take a 5 centimeter distal margin. So that means you have, and you will remove D2 lymph nodes also. So that means after this surgery, something will be like this. तो पलटा होगा इतना टाइम तो सर्जरी में नहीं लगेगा. हाँ? ठीक है. Now, so you have removed the part of the stomach. You have removed a part of the stomach, and you have removed the lymph node. Agreed? So this is called radical gastrectomy. Now you can appreciate that we can't leave it like this, obviously. So we have to establish the communication. So we have various ways of establishing this communication. So what are those various ways? One of the way is this. This is a pancreas. One of the way is I can anastomose this duodenum to this stomach. So when I anastomose stomach to duodenum, when I make a gastroduodenal anastomosis, after this removal of the stomach, this will be called Billroth 1 procedure. This is called Billroth 1 procedure, right? But we don't do Billroth 1 anymore. Earlier we were doing it. We don't do it anymore because there are very high chances of leak, anastomotic leak from this procedure. So we don't do this anymore. Now what we started doing was, we started closing this stump of duodenum. We started closing this part of the stomach, and we started anastomosing jejunum to the stomach like this. And this surgery was named as Billroth 2, right? But we have stopped doing Billroth 2 also. Now what we do, and this is something you have to understand. And when I was at your level, Leave alone understanding, I didn't know even how to pronounce it. It is not Rox and Y. It is Ru and Y gastrojejunostomy. What is this Ru and Y? Let's understand. ये हमने किया है. This procedure you have to understand, then only you will be able to make out what is happening here. So we have done this surgery. Imagine this is a pancreas, and this imagine is the jejunum and ileum, and there's a ileocecal junction. Okay. In what we do in a Ru and Y, any Ru procedure will be like this. There can be Ru and Y gastrojejunostomy, which I am going to explain here. There can be a Ru and Y hepatojejunostomy. There can be any Ru and Y procedure, right? So what we do in Ru and Y procedure, so what we are going to do in Ru and Y gastrojejunostomy, we will close this end of the stomach, duodenum. We will close this end of the stomach also. Now what we are going to do, we are going to divide jejunum. We have divided jejunum, right? So jejunum divide ho gaya. Intestine is quite long. Please, this is a schematic thing, but intestine is a quite long structure. Now this is the proximal loop. This is a distal loop. Agreed, right? So what I'm going to do now, I will take this distal loop, pull this distal loop, and take it to the stomach and anastomose it like this. मैंने डिस्टल पार्ट को खींचा और स्टमक के साथ जोड़ दिया. ठीक है? I have anastomosed distal part of the jejunum and anastomosed it to the stomach. Now you can appreciate this loop, the proximal loop, has all the biliary and a pancreatic secretions. All the enzymes are here in this, right? So what I'm going to do now, I will anastomose this loop to the part of the jejunum which is going towards the stomach side. So this Y which is formed is called Ru and Y. नहीं समझ आया तो बोलना है. क्या किया मैंने? डिस्टल लूप को स्टमक के साथ एनास्टोमोस कर दिया और प्रॉक्सिमल लूप को यहां जोड़ दिया. डिस्टल को स्टमक के साथ जोड़ दिया. I have anastomosed distal loop to the stomach, and the proximal loop I have anastomosed to this limb which was going towards the stomach side. So this limb which is going towards the stomach side is called Ru limb. This limb is called Ru limb. समझ आई बात? बाउंसर तो नहीं गया? Sure? Okay. अब ये सब खेल खेलने की जरूरत क्या है? Why did we do that? What was the reason? The reason is, please try to see the reason. And this is a very important reason. You can see here that all the enzymes, the biliary juice, pancreatic juice, which is alkaline in nature, here will go like this, will go like this, will go like this, and some of them will go to the stomach side also, and then will go to the distal part of the joint. So continuously, this stomach is getting exposed to the alkaline juice. Stomach is not used to alkaline thing. Stomach is used to acid, and now stomach is getting continuously exposed to the biliary alkaline juice. So because of this, the biliary gastritis, or which is also called alkaline gastritis, sets in the stomach, and initially there will be metaplasia, and then there will be subsequently dysplasia. So this can lead to carcinoma. So I don't want that to happen. So what I have done to avoid that, I have done this. So what I have achieved with this, all this will go like this, will go like this, will go like this. Right? But then you can appreciate that some of the jejunal secretions can still go towards the stomach side, but not to the extent. The jejunal juices are also alkaline, but not to the extent which was happening here. So even Ru and Y procedure has a risk of malignancy in future, but not to the extent which Billroth 2 had. So that is why we have shifted to Ru and Y. So there was a question asked in your exam. Now you tell me what will be the answer to this. In out of the following three procedures, which of them doesn't have a duodenal stump? Billroth 1 doesn't have a stump of duodenum there because you have anastomosis, right? In Billroth 2 and Roux-en-Y procedure, we have a duodenal stump. Now, once we remove part of the stomach, see, stomach is not a vestigial organ that you can remove it. So, when you have removed a part of the stomach, you have done a gastrectomy. After that, you may anastomose it by Billroth 2 or you may anastomose by Roux-en-Y. But there will be complications due to stomach removal. So, those complications are called post-gastrectomy syndrome. So, what are the post-gastrectomy complications? We all should know. The post-gastrectomy complications include bleeding, duodenal stump blowout. What do you mean by duodenal stump blowout? Duodenal stump blowout means opening of the sutures of the duodenum. Opening of the sutures of duodenum. And this commonly happens between 4th to 7th day, checked in exam. The opening of the sutures of duodenum, if has to happen, it will happen between 4th to 7th day. More commonly, it happens on 4th day, a question asked. Duodenal stump blowout more commonly happens on a 4th day. Then other complication which we can have is post-gastrectomy. So post-gastrectomy means after surgery only. Dumping syndrome. There can be early dumping. There can be late dumping syndrome. There can be diarrhea. There can be gastrocolic fistula. There can be ulceration, and these ulceration most of the time are on the jejunal side. You know that jejunum is not supposed to receive such a strong acid. Jejunum is supposed to receive the stomach contents after getting processed in duodenum. Now jejunum is getting exposed to the acid, such a strong acid. So there can be ulceration on the jejunal side. These are called stomal ulcers. These are called stomal ulcers. Patient can develop a micronutrient deficiencies also. Like most common is iron deficiency, followed by vitamin B12, followed by calcium. So these complications are called post-gastrectomy syndromes. And you are asked which of the following is not a complication of after gastrectomy. So you should know what are the complications we have after gastrectomy. What is dumping syndrome? There are two types of dumpings, not dumplings, dumpings. There is early dumping and there is a late dumping. Early dumping happens between after 15 to 30 minutes after taking meals. Late dumping happens usually after 2 hours of the meals. Now, what is this early dumping and late dumping? देखो क्या है? You have anastomosed jejunum to stomach. You have anastomosed jejunum to stomach, and jejunum is not supposed to receive stomach content directly. Jejunum was not supposed to receive a stomach content directly. So now jejunum is receiving stomach contents directly, right? So what is going to happen because of this? One such problem is early dumping. What is that early dumping? Now what happens is most of our human food, the food we take, our food is mainly made up of carbohydrate. And this carbohydrate constitute a major bulk of our diet. You all know that carbohydrate constitute a major bulk of our diet, right? And this carbohydrate not only adds bulk to our food, this carbohydrate also add osmotic gradient to our food. And this carbohydrate food which we take makes food a highly osmolar. हमारा जो food है which is that is mainly made up of carbohydrate, and that carbohydrate not only adds bulk to our food but also makes it highly osmolar. अब क्या हुआ कि अचानक से इतना highly osmolar food जो normally was reaching jejunum after getting diluted in the duodenum by secretions of the duodenum now has reached jejunum. So once this highly osmolar food reaches jejunum, the gradient sets in between the food and the cells of the jejunum. And because of this osmotic gradient which develops highly osmolar food and the osmotic gradient of the cell. So what happens is the fluid from the cellular part of the jejunum shifts into the luminal part of the jejunum. Because of this gradient, the fluid from the cells of the jejunum comes into the lumen. So when the fluid comes from the cells of the jejunum to the lumen, body perceives as if somewhere hypovolemia is happening. क्योंकि फ्लूइड सेलुलर कंपार्टमेंट से ल्यूमिनल कंपार्टमेंट में आ गया, तो जैसे ही फ्लूइड सेलुलर कंपार्टमेंट से ल्यूमिनल कंपार्टमेंट में आ जाएगा, बॉडी को हाइपोवोलीमिया के सिम्टम्स आने लग जाएंगे. सो दिस सिम्टम ऑफ हाइपोवोलीमिया which the patient is developing immediately after taking meals is called early dumping. Is called early dumping. So body is going to perceive as if somewhere hypovolemia. What are the symptoms of hypovolemia? The patient will have a palpitation. Patient will have a sweating. Patient will have altered sensorium. Patient may have confusion also. Patient may have headache also. Like whatever we get it in diarrhea, as if we are losing. So same thing will happen in early dumping. Right? Now what is late dumping? Late dumping happens after 2 hours. Now what is this late dumping? Jejunum has a very good absorptive power. इनका करना क्या है अभी हम देखेंगे. पहले हम समझते हैं कि हो क्या रहा है. Jejunum has a very good absorptive power, right? And you have now attached jejunum to the stomach. And now jejunum is exposed to very high carbohydrate rich food. Moment it is presented to jejunum, jejunum will start absorbing it. So this carbohydrate immediately goes into the cell of the jejunum. The moment the carbohydrate goes into the cellular compartment of the jejunum, there is a sudden surge of insulin happens. There will be a sudden surge of insulin is going to happen because carbohydrate, on the command of carbohydrate, we know insulin is released. So there will be sudden surge of insulin going to happen, and because of this sudden surge of insulin, the patient will have a hypoglycemia developing. So body perceives in late dumping as hypoglycemic symptoms happening, and this is called late dumping. So what is important for us? Important for us to know is that early dumping is happening because of an osmotic gradient. Early dumping is happening because of an osmotic gradient, while late dumping is happening because of a sudden surge of insulin. And this early dumping is presenting with symptoms of hypovolemia, while late dumping is presenting with symptoms of hypoglycemia. अब करना क्या है? What to do? The simplest solution which we can easily appreciate is that we should decrease the carbohydrate content of our diet, and we should take frequent small meals. this will take care of both the problems. This will take care of both the problems. And if this is not helping out, we may add octreotide also. So this is a treatment of early and a late dumping. Right? So this is the treatment of the dumping syndrome. And this is what is a post-gastrectomy problems. Okay, now, चले आगे. LARF is left anterior, right posterior. Left or anterior vagus nerve is one and the same thing. Left or anterior vagus nerve is one and the same thing. Right or posterior vagus nerve is one and the same thing. Left or anterior vagus nerve is same. Right or posterior vagus nerve is same. So left vagus nerve is also called anterior vagus nerve. Right vagus nerve is also called a posterior vagus nerve. So the mnemonic for this is LARP. Right? और ये मैंने नहीं बनाया, ठीक है? ये standard books में है. So it is called LARP. और मैं बना भी नहीं सकता mnemonic वैसे भी. Now this LARP we have to understand this. Now this is the left vagus nerve. The left vagus nerve comes like this, and it gives rise to two branches: the hepatic branch and a gastric branch. The left vagus nerve divides into hepatic and a gastric branch. Okay, and this gastric branch gives multiple terminal branches like this. The gastric branch gives multiple terminal branches like this. The hepatic branch gives a supply to the liver. Hepatic branch gives supply to the liver, to the gallbladder. The hepatic branch gives supply to the liver, to the gallbladder, and it also gives supply to the pylorus of the stomach like this. Hepatic branch is giving supply to the liver, to the gallbladder, and to the pylorus of the stomach also. Right? Now, then there is a right or a posterior vagus nerve running like this. Right or a posterior vagus nerve is running like this. And this right vagus nerve gives multiple terminal branches like this. Again, so this is how the nerves are supplying stomach. Now, very important point to note in this is all these nerves supplying pylorus of the stomach, all those branches of the vagus nerve which are supplying pylorus of the stomach are called nerves of Letard-Jets. All those branches of the vagus nerve which are supplying pylorus of the stomach are called nerves of Letard-Jets. And this particular branch, important point, this particular branch which is arising from the right or a posterior vagus nerve, this particular branch is supplying the antrum of the stomach, and this part of the stomach has a maximum cluster of gastrin secreting cells. Right vagus nerve से ये particular branch जो आई, this particular branch is supplying the part of the stomach that is antrum, and that antrum part of the stomach has a maximum cluster of gastrin secreting cells. And this particular branch of the right vagus nerve, important point is this particular branch of the right vagus nerve is called nerve of Grassi. So nerve of Grassi is a branch of right vagus nerve. Nerve of Leytargids are the nerves which are supplying pylorus of the stomach. Right? We have to remember this. The nerve of Grassi is a branch of a right vagus nerve, while nerve of Leytargids are all those branches of the vagus nerve which are supplying pylorus of the stomach. So we have to know this, and this will be having its role when we talk about management of a peptic ulcer disease. So this was something important in the surgical anatomy which we should be knowing. Now you want me to take a break or continue? So let's take a break here.